Concussion. What is it exactly? How do we assess for it? And what do we do to manage it? This is a condition that can get very emotional and heated for a few reasons. First, everyone knows about concussion. They hear about it constantly in sports or in everyday life, which means that everyone has an opinion on the matter. And patients and parents may be very vocal about what they need you to do about it. Also, concussion affects individuals in unique ways. Their mood, their coping behaviors before and after that blow make a huge difference in symptom burden and recovery. A lot to talk about, so let's get right in the game.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Concussion is a type of traumatic brain injury, and with any injury, the timing, the context, the severity, and really the individual will influence the disease burden. In 2017, the Concussion in Sport group renewed their consensus statement and modified the definition of concussion, which, quote, may be caused by a direct blow to the head, face, neck, or elsewhere on the body with an impulsive force transmitted to the head. It typically results in the rapid onset of short-lived impairment of neurologic function that resolves spontaneously, but in some cases, signs and symptoms may evolve over a number of minutes to hours. Quoting further from the consensus, quote, concussion may result in neuropathological changes, but the acute clinical signs and symptoms largely reflect a functional disturbance rather than a structural injury, and as such, no abnormality is seen on standard structural neuroimaging studies. And lastly, quote, concussion results in a range of clinical signs and symptoms that may or may not involve loss of consciousness. Resolution of the clinical and cognitive features typically follows a sequential course. However, in some cases, symptoms may be prolonged, unquote. Just to add to this, of course, the clinical signs and symptoms shouldn't be explained otherwise, for example, by the use of drugs or alcohol or other depressant medications or the effects of other injuries. So what happens at the cellular level? What do we need to know to understand the scope of this injury? To answer this question and more, first we need to dive deep into Newtonian mechanics. Okay, just kidding. But to conceptualize what happens to our concussed brain, consider the common scenario when you're driving along, minding your own business, and someone cuts you off, and they stop abruptly. You slam on your brakes, and your car stops before hitting the other car. But even though your car has stopped, you're still in it, and you're a separate entity from your car. So you continue to move forward until you're somehow stopped by another force. Maybe that's the force of your seatbelt, or the force of your latissimus dorsi and paraspinals holding you back. Maybe it's the airbag, but you need some other force to counteract the motion that you are going through in space. And that, my friend, is an example of Sir Isaac Newton's first law. An object either remains at rest or continues to move at a constant velocity unless acted on by another force. So, if your skull and your brain inside it, both of them are traveling in space and something stops your skull, or vice versa, your skull stops an external object, you get a mismatch of forces and an inevitable collision occurs. With a blow to the head, you get a type of rotational acceleration with multiple vectors involved and subsequent shearing forces. Why rotational? Well, not all parts of the brain will decelerate at the same rate. The higher functioning areas of the brain, after all, they form a big C that curves around the midbrain. Think of your midbrain as the base that the rest of your brain fans out from. Kind of like the old-fashioned folding hand fans that ladies would use to cool themselves off. With a flick of that wrist, the spokes of the fan spread out or retract. With the same amount of acceleration-deceleration energy, the base doesn't move much, but the ends of each spoke will. So think of the ends of the fan as your cortex. The higher executive functioning areas take the biggest beating because they move the most. Now, we know this injury model because it's been demonstrated in animal and human models. It turns out the site of impact doesn't correlate with severity of symptoms, but we do know through national surveillance projects from the 1970s and on that impact on the apex of the skull is twice as likely to cause a concussion than from any other blow to the side or the front. The sheer forces cause a few phenomena that later wreak havoc on the brain's function: depolarization, changes in cerebral blood flow, and metabolic chaos. First, the impact triggers a maladaptive response. The sodium-potassium channels on the neuronal membrane allow a massive influx of sodium, and they kick out the potassium. The calcium channels allow the release of the excitatory amino acid glutamate. This kicks out even more potassium out of the neuron. And so very rapidly you see a depolarization of the injured neurons. But since neurons are really good at giving and receiving messages, all downstream neurons are sent a signal to depolarize as well. Your brain's higher center function is, in effect, depressed. Now, neurons get depolarized all day, every day, up to 200 times per second. But once a neuron fires, it quickly resets so that it can receive a stimulus right away. Sort of like when you push the button, reset button on your computer, it'll reboot and then it'll start again. The problem here is the signal that causes the depolarization, it's not normal. A normal signal allows for a normal repolarization and resuming of function. With a concussion, the damaged tissue is constantly sending the depolarization message to the rest of your brain. It's like holding the reset button down on your computer until your finger loses feeling, and then holding it some more. With all of this electrolyte dysregulation, it's no surprise that when your ion channels are unhappy, everyone is unhappy. Remember our good old friend, the sodium-potassium pump? It's also called the sodium-potassium ATP pump. Use up all your ATP? All right, well, let's just throw some more glucose on there and you'll make some more. Uh-oh, are we running out? Well, we all know what happens when we run low on our sugar. Your neurons get hangry. Glycolysis happens, and so does our friend, lactic acid. Chaos is not a metabolic pit. Chaos is a lactic acid ladder. Just to add insult to injury, we see decreased cerebral blood flow in concussion. This is a loss of the normal autoregulation. So, at a cellular level, there's a glucose supply and demand mismatch. Now, with less perfusion to the brain, there's even less glucose and less oxygen supplied to parts of our brain. When your brain doesn't get its basic nutrients, it slows down, way, way down. Concussion is a big problem for the individual and for society. We really don't know the incidence or prevalence of, by the way, what's the difference here? Remember, incidence is the number of events that occur in a certain time frame. Prevalence is the number of people living with the disease. And of course, these terms are going to depend on the process we're talking about. So the incidence of, say, invasive breast cancer may be 250,000 per year in the US, as an example. The prevalence of the disease, the number of people living with it right now, is about 3.5 million currently. Incidence is an event per time. Prevalence is a count here and now. This is troublesome for concussions, right? Because the event has to happen, but the duration of symptoms, or whether they're reported or not, can be variable. There may be close to 4 million sports-related traumatic brain injuries in the U.S. per year. Most of them are going to be concussions. That number should really blow our minds. Of course, the high-impact sports that are the biggest offenders, rugby, American football, ice hockey. But I have to also say this, though. Soccer, if it's played by girls, watch out. Among women and girls, soccer, or internationally football, of course, is associated with the highest incidence of concussion. Do not get between a woman and her soccer ball. Whether we're just getting better at the diagnosis, or maybe it's just on people's radar because of the high exposure of celebrity players, the diagnosis of concussion has risen dramatically since 2000. So, how do concussions present? Before we go into the long list of all of the non-specific signs and symptoms that can be associated with concussion, let's do a quick huddle. Listen, if you're on the fence about calling it a concussion, it's totally okay to overcall it. Now, we have to be careful here because there are certain diagnoses you don't want to overcall. Should you overcall, say, pneumonia? Well, not necessarily, because you want to protect the patient from an unnecessary treatment that may bring more harm than benefit. You can think of all of the various diagnoses that you want to be careful about over or undercalling. But concussion, just do it. There is no perfect way to make the diagnosis of concussion. Field testing is great, and we'll talk more about it, but the truth is, the patient has made his way to your ED one way or the other, with a worried family member or friend, or with his coach who was also concerned, or maybe after a motor vehicle collision, a fall, and the list goes on. My point here is that everyone is worried about concussion. You gain no extra cowboy points by being too rigid with a diagnosis. By calling it for what it is, or for what it very well may be, you're giving them some solace in a plan of action. A plan for the care of this episode, and hopefully some counseling to prevent another. All right. What are the symptoms compatible with a brain concussion? A lot of these are intuitive. You see this in your everyday life, but let's go through a few. Headache, of course. Confusion. Now, that may be a lack of comprehension or just disorientation. It's funny because often people who are concussed are not necessarily globally depressed, like in a substance ingestion, but they're weirdly good with some parts of the history and like seemingly totally flaky with others. So don't blow it off that you think that they're just acting. Take the disorientation seriously. The patient may just have a blank stare or be inattentive, but it may be so bad that you see slurring of speech. Dizziness. It's almost universal along with a headache. Maybe you have some vomiting or some trouble with gait. There may be mood swings, even acutely. I once saw a young adolescent who was talking to me, and he had a very serious face with me, and then he would just glance at his brother, and he started to laugh uncontrollably. When I tried to redirect him to get some more information out of him, he got angry with me, and then he glanced at his mother, and he immediately cried inconsolably. This was in the span of a very short and honestly not too helpful interview. I'd say maybe in the span of 2 minutes, he had the range of emotions. It was remarkable and real. Remember, one trauma begets another trauma. As always, do a thorough total body check for other injuries. Also, other things that may be going on instead of or along with a possible concussion, think of heat illness, hypoglycemia, dehydration. Don't let all of the external hype take you off your focus to see your patient as a whole and not just his chief complaint. Do a great spine exam. Paresthesias or numbness, even stingers, should get your attention. It's fine to put someone in a C-collar if you're unsure until you have more time to figure this all out. Of course, don't be fooled. This may be more than a concussion. A focal neurodeficit is not a concussion. Signs of basilar skull fracture? Well, we're out of simple concussion territory now. Seizure? Sure, I guess that is still possible, but blood is very irritating to the cortex as well. If the child or adolescent appears well, and he's eligible for using the PCARN criteria for clinically significant mild traumatic brain injury, then use that to help you decide about imaging. Remember, these are decision tools to help you do what you think is right. They're not decision rules. The PCARN police will not come after you. Do what you think is right. If that means you're worried about hemorrhage, by all means, go looking. If you're unimpressed and the child meets low-risk PCARN criteria, it's okay to call it a concussion without confirming with imaging. Now, this may or may not go over well with parents. People nowadays are conditioned to have to fight to get what they need or what they feel they need. In our modern society where everyone is a number, everyone is anonymous, it's difficult. We need to hold for the next representative. It's no wonder that we, who are often seen as authority figures, and maybe symbolically the establishment, whatever that means, it's no wonder that sometimes people get so frustrated that they blow up at us. Just stay low and keep it humble. Take the time to listen. Then listen some more. Even if you know the treatment plan before the first words come out of their mouths, just listen. Those extra few minutes of planting the seed of rapport and trust will reap huge benefits in avoiding miscommunication, mistrust. It may even avoid some return visits or some doctor shopping and just plain angst and rage against the machine. Well, there's always that nagging question. What would a CT show you? Well, blood and broken things. Concussion cannot be diagnosed by CT. If you can see it on CT, it's not a concussion. Even standard MRI does not show changes in architecture. Now, if you were to do, say, a functional MRI, maybe for research purposes, it's not part of the standard workup or the follow-up for concussion, but sure, maybe with functional MRI, you might be able to see that it's a concussion. As long as you do a good, thorough history and physical exam and talk with collateral, really get a good sense of what happened, the mechanism, and the patient has a reassuring exam. If you're not looking for blood or broken things, then make that clinical assessment. Use your history prowess and your physical exam superpowers and make the clinical diagnosis of concussion. The extra time that you took to talk and examine and listen and answer questions will make the precautionary advice you give so much safer and more effective. Before we go on, speaking of assessment, let's just go through a few popular field tests. These are really designed for field screening. Your thorough history and physical should include these components and go even further, but it's good to know what's done on the field, by the bench, pre-hospitally, so that we can communicate with everybody and be well informed. Coaches, trainers, and those who are not clinicians will often use a screening tool called the Concussion Recognition Tool. The 5th edition is out as we speak. Step 1. Any red flags? Call the ambulance. These are all pretty fair. Neck pain or tenderness, double vision, weakness or tingling, seizure, loss of consciousness, vomiting, etc. If they have none of those, then they'll go to step 2. Observable signs. Is the player lying motionless on the field? Is he slow to get up? Is he disoriented or with a blank stare or vacant look? Does he have any balance trouble? Is there any obvious head or facial trauma? Step 3 for coaches. Assess for symptoms, like all of the concussive ones that we just talked about. And lastly, step 4 is the memory assessment. They ask very fair questions that would be very important to the player, like, what venue are we at today? Who scored last in this game? What team did we play last week? Etc. Although it still feels like anyone with anything is still referred to the ED, it's good to know that coaches and other non-clinical staff are paying attention, and they may have very valuable information to share with us. Every team should have a protocol on what to do about suspected injuries and concussions. The National Athletic Trainers Association has great resources on this. There are many concussion tools and scales for use in the field, but the most famous and widely used is the SCAT, the Sports Concussion Assessment Tool. It's also part of the same collaboration as the coach's version. SCAT is to be used by physicians or other well-trained clinicians. There's also a version for those 5 to 12 years of age and another one for 12 years and up. We won't go through all of the details here, but it's good to review the components. Again, they use a stepwise approach. Step 1. Like the previous, call an ambulance for high-risk features like neuro findings. Step 2. Observable signs, as we mentioned. Then step 3 is a little more sophisticated than the coach's version. They get a GCS and a cervical spine assessment. The reason I mentioned SCAT as a resource is not for all of those things. They're very cut and dried, and you're going to do all of those things anyway. It's because the newer editions include an office or off-field assessment. Take a look at the show notes for a link. It helps direct our history and physical about all the pertinent parts of the history, like previous concussions or comorbidities. Then there is a great symptoms inventory. It's like a checklist. There's a separate scoring for what the child reports and also for what the parent reports. There are cognitive tests of memory and concentration. There's a neuro screen, balance testing, delayed recall, and decision making. Now, a lot of this is not what we would necessarily do in the ED, and SCAT can't be done in less than 10 minutes. So it kind of really reminds me of the NIH stroke scale. It's very detailed and it's very scripted. But take a look, not necessarily to adopt its use in the ED, but mostly to inform us of these types of questions that may be helpful in diagnosis. Another little tip here, for the very anxious family members, you may want to pull out the latest SCAT and sit down for those 10 minutes. Show them your work. It may make all of the difference. Okay, Tim, we got it. The kid's got a concussion and we don't need to image. So what now? How can we help the patient and the family care for him or her? The biggest complaints acutely are usually headache, nausea, and dizziness. Luckily, we can treat all three with your standard cocktail, either by mouth or IV. So acetaminophen or paracetamol and maybe PO ondansetron, they're fine. Or if you want to go IV, you can do your normal treatment for primary headache like prochlorperazine. After addressing the symptoms and a little time to cool off, the vast majority are able to go home. It's very rare that we need to admit someone for concussion. Reasons to admit are inability to walk, major balance issues, and inability to tolerate liquids by mouth. At that point, there's overlap with more serious issues, and you've probably already done your CT. Now, if you're otherwise unconcerned, a negative CT is a great way to get people home if that's at all possible. Just use your best judgment as you always do. Another little tip, it's very useful to know and to counsel that 90% of sports-related concussions will resolve within 2 weeks. Okay, there is always a lot of discussion about return to learn, going back to school, or return to play. The short version of this is that it's not for us to take on. Not only do we not have the time or relationship with the patient to make the best determination, but he or she will also need serial examinations and hopefully from the same doctor. There will inevitably be lots of follow-up questions and concerns and management issues. Although you may feel pressured to clear the child or adolescent to go back to school or play, it's just not the right setting to do so. The more severe the initial symptoms, the longer the recovery. Girls often have a harder time recovering, or at least there's an association with female gender and prolonged recovery time. It may have to do with mechanism. Those with established running diagnoses of ADHD or mood or learning disorders have a higher risk of more severe symptoms with a longer duration. Remember that we want to avoid the second impact syndrome at all costs. The recovering concussed brain is very vulnerable to injury. A second concussion during this time can lead at best to very severe and very prolonged symptoms, and at worst, up to massive cerebral edema and death. Which leads us to prolonged symptoms. When do we call it post-concussive syndrome? Well, no one really knows, but a rule of thumb is that if symptoms are not improving within a month or so, the child or adolescent is going to need much more support and careful follow-up, and this is very likely to be post-concussive syndrome after about a month. Again, this highlights the need for continuity of care, which does not include serial ED visits with different doctors. The patient truly needs repatriation to his primary doctor. So what can we do in the ED? We can talk to them and we can introduce expectations. Let them know the steps. Let them know that this is a process of diagnosis and management. It's going to take time. Be patient with yourself. Be patient with the patient. But in an interest of making us better clinicians and also helping us to counsel our families, let's do a little review of the literature as it stands right now. Return to learn. There's been a lot of back and forth in the literature recently about physical rest and brain rest. Traditionally, the recommendations sounded like the only thing a person with concussion could do safely is to stare at a blank wall. No reading, no TV, no deep existential thinking. We can all guess how those recommendations were taken. Purcell et al. In the British Journal of Sports Medicine recently did a systematic review of studies concerning return to school after concussion. A systematic review was needed because of the varying findings in studies and the relatively small numbers of subjects. By the way, what's the difference between a meta-analysis and a systematic review? Well, they both gather pertinent studies. They both have inclusion and exclusion criteria for those studies. They both try to gain a better global understanding of the literature by pooling researchers' efforts. But they differ in a few important ways. A systematic review has a specific question and goes about gathering evidence in a transparent, logical, and systematic way. It's like a mega book report on a specific question. A meta-analysis is just that. It's an involved, sophisticated way of combining data across studies to get a more accurate assessment of what may or may not be the truth by pooling all of the subjects across different study designs. So you can readily see the pros and cons and the strengths and weaknesses of each. Okay, tangent over. Return to learn. Basically, it shouldn't be all or nothing. It should be incremental. Purcell et al. Recommend that the school have a policy for accommodating children who are recovering from concussion. They should start with having the child work on tasks 10 to 15 minutes long. And if they can tolerate that, over time they can work up to 30 to 45 minutes, which is usually the amount of time needed to get through a lesson or a block. If a child can get through a full-length subject without break, he can probably resume a normal school schedule. So, let's be honest. Nobody is really chomping at the bit asking, when can he go back to school? I'm just being real with you. What they really hound you about is, when can he go back to play? It's not so dangerous that the child goes back to school too early, but it is potentially dangerous to go back to play too early. We can argue whether physical exertion slows symptom resolution, but what we really need to avoid, and this is a big deal, we need to avoid a second concussion while the player is recovering. There is an exponential increase in duration and severity of symptoms, not only with each subsequent concussion, but also with a concussion during the recovery process. You may be reassured to high heaven by coaches, by parents, and especially by the eager player that this is not going to happen. But remember, people who push you to return to play just want your name as an insurance policy if there's ever any issue. Don't go playing that game. There is no need to rush back to play. It's much better to lose a season than to take that second hit and its exponential consequences. You can always have another season, but you can never get back this chance right now to do the right thing for your safety and, frankly, for your future independence and productivity in life. All right, let me break it down for you again. Here's the thing. Concussion happens. It's more common than we realize. With a normal neurologic exam and no high-risk features, many children do not need imaging. Imaging is looking for blood and broken things, not for concussion. Players need a cooling off period. Clearing for return to learn or return to play is best left to continuity care. Our role is to help them know what to expect in the next few days to weeks and give them good precautionary advice. Lastly, take the time to explain the evidence, give them guidance, let them vent, or even plead with you, but be firm about precautionary advice and return precautions. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.